Hi, this is Roger Green, host of the Surfing the MASH Tsunami podcast. This week, we're offering 5 conversations from episode 20, our review of drug development stories from the EASL Congress 2024 with Jörn Schattenberg, Naim Alkhouri, and Mazen Noureddin, plus from the Vault, one of our wrap-up conversations from the EASL Congress 2023. This conversation starts by continuing the discussion of induction versus maintenance therapy for FGF-21s. Mazen responds to Naim's comment by questioning why we would regard Efruxifermin as an induction therapy, given that its safety and tolerability appear comparable to the oral agents, if not in some way superior, and that it maintains such a high level of efficacy over time. In fact, he adds, its sustained efficacy might make it possible for livers over time to eliminate fibrosis entirely, get MAS scores down to 0, and return to essentially a normal state, almost like a, this is Mazen's word, cure. He wonders whether it's possible we can give patients drug holidays at that point, or even discontinue medicine altogether. Jörn shifts the discussion to make sure we cover pegozafermin, another FGF-21 in development. He notes that this is a pegylated molecule, which makes it different from efruxifermin, and comments on a low level of dose response, but strong sustained response at 48 weeks. Mazen reiterates his optimism about the class in general, reminds us that there's a third FGF-21 in development, this one from Boston Pharmaceuticals. At that point, I recall Michael Charlton's question from Season 5, Episode 11, that an induction therapy strategy for FGF-21s might not work if removing the drug allowed MAS activity to return. On the other hand, I note, it might take years for fibrosis to return given how slow the natural progression of the disease normally is. Mazen agrees that many unanswered questions around issues like this exist, but he reiterates his belief in the long-term therapeutic value of the class, however we ultimately choose to deploy it. During the episode, all of us kept comparing the negativity and virtual despondence of the 2019 to 2020 period described as the graveyard with what's described as today's gift shop of multiple modes of action, demonstrating clearly positive results. It's an exciting time for the field and for the patients. As I edited, I found myself thinking of Stephen's goal to put a big fat dent in fatty liver disease. We all can use this episode to gauge the size of Stephen's dent, and frankly, it's pretty damn big.
Mazen Noureddin.
Let me comment on this really quick. So I just want to comment on the induction. And some people started proposing FGF-21s. No, I'm not saying you, Naim. It has been for a while as induction therapy, but I'm starting transitioning into not calling them induction therapy. The reason why here you see additional benefit beyond 24 weeks, it was well tolerated, in my mind, better tolerated than GLP-1s and duals up to 96 weeks. And you're seeing two-stage improvement. So it will be a pity to stop them early and kind of stop that effect. In my mind, I want to eventually see analysis going from at-risk MASH to MASH, more importantly, from at-risk MASH to MASLD, or even resolving the entire thing, right? Like what we did with PDFF, more than 70%, and then said, let's do other things like looking at PDFF less than 5% and ALT normalization, which means probably a cure. And they, with the Efruxifermin, they did that in their, I think, the Nature Medicine paper when they showed on the PDFF less 5% and normalization of ALT. So it will be interesting, and let me throw this hypothesis. Efruxifermin being given to 3 years and it reverse your MASH and fibrosis, and you go either for simple steatosis or even cure. So I wonder if it will not be induction therapy in the future, or all the FGF-21s, or rather 2 to 3 years treatment. I don't know. I mean, resmetirom is now in the market. We'll see the long time effects. We'll see what we combine, but back to your 2019, Naim. So we were being looked at as oh, your biopsy is hard, the field is difficult, no investors and all this. And look at the last year. Despite the biopsy, which I totally think should go away, and that trial is going to be more difficult with a drug on the market with NITs and having placebo and yada yada, still we've done it. So I look forward to the next year.
Naim Alkhouri.
Yeah, I like the concept of a MASH cure, but at the end of the day, if you cure the disease after 2-3 years, depending on the cost, but it might be a good idea to transition to a cheaper, more tolerated medication, especially, now we're seeing more young adults progressing to F3, some, young adults in F4. F4 is a different beast, but if I have someone with F3 that we started FGF-21 at the age of 35, and now by 40, they have nothing left, maybe it would be nice to stop and see what happens. So many unanswered questions also. Another question that we keep hearing about is, well, can you stop resmetirom? For how long do you treat? If you start someone with F2 and now they have F1, it doesn't make sense reasons to stop. I think our conventional thinking now is, you don't stop treating diabetes when the A1C gets better unless someone lost, 50 pounds and they're committed to a lifestyle and you have reasons to believe that the disease will not come back with vengeance. So that might be a scenario also with resmetirom. If someone takes the medicine but they commit to a very intensive lifestyle, that we give it a chance and stop it for 6 months after, 2-3 years and see if there's any rebound or the disease coming back. Going back to being in the gift shop now, it's really a good position to be in with having multiple options and thinking about maybe stopping treatment after some time and see if you can transition to a different drug or maybe just stop medication altogether and hopefully maintain that response.
Jörn Schattenberg.
Let's quickly discuss the pegozafermin too, because we have the FGF-21s, and I think the molecule is interesting because it has a little different setup, right? So it's pegylated and not FC linked, giving it a little bit different pharmacodynamics. And the data is published in the New England phase 2, but the data set we saw here now presented is the response on or maintenance of response on NITs. MRI-PDFF is the primary readout at 8 weeks 48. I think that it's not a very strong dose response there. We didn't see dose response, but enzymes went down and were maintained. So I don't want to do deep analysis of an extension of the phase 2 where the numbers are not that big. But again, if you look at the NITs, it shows that extension and not loss of efficacy is something that we're seeing here.
Jörn, I'm really optimistic about FGF-21s, and I was just talking about Efruxifermin. I think pegozafermin is very promising, and there's another one coming by Boston Pharma, another FGF-21 which also will be presented hopefully at the EASL. That is a very interesting one with different dosing. Pegozafermin, I don't know if I'm wrong, I want to still look at the tachyphylaxis with pegylated product. I think they had an excellent result that they published in the New England Journal. To me, being reviewer number 2 here, if you want, that placebo response of 2 and 7%, something I have not seen in any other NASH trials, regardless of the explanation and the way they read the biopsy or any even chronic disease. So I hope that will hold true in their phase 3. I look forward to seeing their results. Again, I think they have something exciting and exciting MOA, but I think we have to keep an eye on the prize with these FGF-21.
Roger Green.
Quick question, and then I want to make sure we get to touch on denafenstat and a couple of other things. Okay. So question number 1 is, Michael Charlton made the point earlier that if FGF-21 is a unique mode of action and you stop the drug, does that mean that eventually the patient reverts to whatever problem they had in the first place? Flip side to that, Mazen, is if you get to cure, given how slow the progression of this disease might be, and it's going to take 20 years for the patient to get back to where they were, 15 years, do you really care? So number 1, do we think that's legit? Number 2, do we care? And then I want to go on to other modes of action, at least for a little bit.
Roger, as you said, and Naim mentioned, there are a lot of unanswered questions. Let me give you an example now from the GLP-1. Do you think people that they're taking semaglutide or tirzepatide in obesity and keep taking this as maintenance? No, they take them. I mean, we see them. They lose weight. Some people lose 30 pounds or 40 pounds, and BMI is down from 37 to 33 and 32. They feel happy and good, and they stop it because they want to go back and eat and drink. Some people actually drop beyond BMI of 30, and a lot of people stop, and then they go back weight and they go back. So I wonder if similar thing will happen in NASH if you get to reversibility of MASH and fibrosis and gut steatosis. People will stop drugs on their own. So I don't know what the future will bring us. I think what Naim mentioned makes a lot of sense, that after you reverse fibrosis to a 0, hopefully, and MASH at least to simple steatosis or none, you have something maintenance. And in my mind, that will be between orals like resmetirom or something versus GLP-1s, that they keep the weight down and metabolically down to a certain degree. Of course, maintenance therapy has to be well tolerated, well priced, and all these things.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of the conversation or the entire episode, please put them in the reviews section of the page from which you downloaded this conversation, or send an email to questions@surfingmash.com. Next week, Frank Taka and Luca Valenti from the EASD, EASL, EASO combination group will be joining us to discuss the updated clinical practice guidelines for Mazen. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.